السلام عليكم. صباح الخير يا دكاترة. احنا النهارده we are going to discuss about one of the endocrine cases that we face in our clinical practice, which is Cushing syndrome. So before starting about Cushing syndrome and the classification of Cushing syndrome, let's agree together about the definition of Cushing syndrome. So we know that Cushing syndrome is due to excessive level of cortisol present in the blood. So the Cushing syndrome is considered to be a syndrome with a group of signs and symptoms due to high exposure of the tissues to cortisol level. So inappropriate high exposure of the tissues to what is known as glucocorticoids, or in other words, medically known as cortisol. The most common cause of presence of high cortisol level in the blood is iatrogenic administration of steroids. Those patients taking exogenous source of steroids to whatever the indication. Maybe sometime the patient may take steroids due to an immunosuppressive treatment. Maybe, for instance, the patient is having an autoimmune disease, as an autoimmune rheumatoid arthritis, systemic lupus, systemic sclerosis, by which the patient is prescribed or recommended to take steroids as a part of his therapy. Sometimes the patient takes steroids because of his allergic condition. Maybe the patient is having bronchial asthma. This is why the patient is recommended to take steroids. In other circumstances, patients may take steroids due to anti-inflammatory effect of steroid. The patient is having severe inflammation, by which he was prescribed steroids. So steroids could be given due to multiple causes in clinical practice, and the most common cause of Cushing syndrome in clinical practice is considered to be exogenous administration of steroids. So whenever you are going to find a patient with manifestations consistent with Cushing syndrome, so the first thing that's going to pop into your mind is that the patient is taking steroids. So the first question that we are supposed to ask our patient about: are you taking steroids, yes or no? Why are you taking the steroids? What about the indication to take this steroid? For how long are you taking the steroids? And what about the type of steroid and the potency of steroid that you are taking? However, it is a rare condition to have endogenous source of elevated cortisol level in our blood. So we are going to classify Cushing syndrome into exogenous administration of steroids and endogenous hypercortisolism. So exogenous is considered to be the most common cause, and endogenous hypercortisolism is considered to be a rare cause for this syndrome. Let me at first refresh your mind by the hypothalamic pituitary adrenal axis. So we are having the hypothalamus and the anterior pituitary, the upper controllers of the adrenal gland. The hypothalamus is going to release a releasing hormone, a substance known as corticotropin releasing hormone. This corticotropin releasing hormone will ultimately act on the anterior pituitary corticotroph secreting cells, leading to secretion of what is known as ACTH, which is adrenocorticotrophic hormone. This adrenocorticotrophic hormone is going to act on the adrenal cortex and will lead to the secretion of glucocorticoids. So the ACTH is going to act on the adrenal cortex, namely the zona fasciculata, and the zona fasciculata is going to release what is known as the glucocorticoids or the cortisol. Mind you that the endocrine system is having a very tight system for its regulation known as the feedback mechanism. So for instance, if the patient is having a high cortisol level, there would be a loop negative feedback suppression on the hypothalamus and the anterior pituitary, leading to suppression of the CRH and the ACTH, and leading to suppression of the high levels of cortisol, and vice versa. If the patient is having a low cortisol level, it is expected to have a negative feedback stimulation of the hypothalamus and the anterior pituitary, leading to elevation of both CRH and ACTH, leading to restoring the normal levels of cortisol. This is known as the feedback mechanism. It is vice versa. The arrows are going into the opposite direction. So let's think about what are the causes of endogenous hypercortisolism. And as I told you previously, that we are having the upper controller, the CRH coming from the hypothalamus, the ACTH coming from the anterior pituitary, leading to control of the secretion of cortisol out of the two adrenals. So if I'm having a high cortisol level, I'm expected either to have a problem in the pituitary leading to excessive elevation of ACTH, this is why the cortisol is elevated, or on the other hand, the adrenals themselves, they are leading to excessive elaboration of high levels of cortisol. So we are going to classify endogenous hypercortisolism in what is known as ACTH dependent Cushing, and in other words, the ACTH is high, this is why the cortisol is high, and in ACTH independent Cushing. In other words, despite that the ACTH is low, the cortisol is low. It goes with an adrenal source of hypercortisolism. The most common cause of endogenous hypercortisolism in adults, endogenous hypercortisolism in adults, is ACTH dependent Cushing coming from a pituitary cause. So if I'm having, for instance, a pituitary adenoma leading to secretion of a high levels of ACTH, they are going to go to both adrenals, leading to secretion of high levels of cortisol. This is known as ACTH dependent Cushing due to pituitary cause, known medically as Cushing disease. So if I'm going to tell you that I'm confronted with a case of Cushing disease, so in other words, I'm having a case of ACTH dependent Cushing coming out of a pituitary cause due to the presence of a pituitary adenoma, either a micro or a macro adenoma. And let me tell you that the difference between a pituitary micro and macro adenoma mainly is dependent upon the size. Those having microadenoma are having a tumor mass less than 1 centimeter. Those having a macroadenoma having a tumor mass more than or equal 1 centimeter. Commonly, cases having Cushing disease, they are having a pituitary adenoma which is said to be a microadenoma. That's to say it's less than 1 centimeter. Other causes of ACTH dependent Cushing, which is quite rare, is to having a ectopic site for production of ACTH. Some cells are not designed to secrete ACTH, and if they are going to secrete ACTH, they are not going to be normal cells, they are going to be malignant cells in what is known as paraneoplastic syndrome. So the meaning of paraneoplastic syndrome, that I'm having a neoplasm, most probably malignant, and because of the presence of abnormal cells, they are going to elaborate abnormal substances and abnormal hormones, among which would be ACTH, leading to ectopic site from production of ACTH apart from the normal site that Allah subhanahu wa ta'ala is supposed to secrete it from. So normally ACTH is ultimately and exclusively secreted from the anterior pituitary. If it is going to be secreted from an ectopic site, so most probably this site is a neoplastic site. The most common neoplasms secreting ACTH are said to be squamous cell carcinoma of the lungs, carcinoid tumors, which we consider to be a neuroendocrine tumor, and pancreatic tumor. These are the top 3 tumors causing elaboration of ectopic ACTH out of the neoplastic cells. Theoretically, any endocrine tumor may end up with ectopic production of ACTH, but what I have just told you are the top causes of ectopic ACTH secretion. So if I'm having an ectopic site for ACTH secretion, they are going to act on both adrenals, leading to excessive secretion of cortisol and again ACTH dependent Cushing. Very, very, very rare. They are considered to be case trappers to have an ectopic site for production of CRH, the one coming from the hypothalamus normal. So the CRH is going to act on the anterior pituitary, leading to secretion of ACTH and consequently leading to secretion of cortisol and ACTH dependent Cushing. So the possibility of ACTH dependent Cushing, most probably if I'm having a pituitary tumor leading to ACTH production, which is considered to be the most common cause, or less commonly and considered to be a rare cause, is what is known as ectopic Cushing from an ectopic ACTH or ectopic CRH production. The other classification, the other way along of Cushing syndrome, is considered to be ACTH independent Cushing. And the meaning of ACTH independent Cushing, that ACTH is low, and despite ACTH is low, cortisol is high. And that's to say that the adrenals are secreting high levels of cortisol, direct exposure or direct release from the adrenals themselves. So as a negative feedback mechanism, the pituitary is going to be suppressed and this ECTH is going to be suppressed. So if you're having a patient having a high cortisol level and ECTH is suppressed, so most probably you are facing a case with ECTH independent Cushing due to adrenal cause, either due to the presence of adrenal adenoma or carcinoma affecting one of the adrenals. And the most common cause of ECTH independent Cushing is considered to be unilateral adrenal adenoma, that's to say a benign lesion, less commonly due to adrenal carcinoma, adrenocortical carcinoma, leading to high levels of cortisol as a negative feedback mechanism, suppression of CRH and ECTH, or rarely the presence of adenomas or tumors affecting both adrenals, either microadenomas or macroadenomas, known as micro or macronodular hyperplastic adrenals, leading to high level of secretion of a cortisol, negative feedback inhibition on the ECTH, and leading to ECTH independent Cushing. So this is the classification of Cushing syndrome. Mind you that exogenous hypercortisolism is considered the most common cause of Cushing syndrome in our clinical practice. Less common and a rare condition to have an endogenous hypercortisolism, classified either into ACTH independent Cushing. Let's substitute this term by the ECTH is high, this is why the cortisol is high. The most common cause is the presence of pituitary adenoma, either micro or macro, what is known as Cushing disease. And as I told you, microadenomas are the most common prevalent adenomas in cases of Cushing disease. Ectopic ACTH production or ectopic CRH production under the heading of ACTH dependent Cushing. On the other hand, ECTH independent Cushing, let's substitute this term by the cortisol is high as a negative feedback inhibition. ECTH will be suppressed, so this is considered to be an adrenal Cushing, adrenal source of production of cortisol, either due to the presence of adrenocortical adenoma, carcinoma, or micro or macronodular adrenal hyperplasia. This is considered to be the broadest classification of Cushing syndrome. So how am I going to diagnose a case of Cushing, as we are commonly doing when we are tackling a diagnostic approach of any disease? We are going to start by history taking, and then we are going to proceed to physical examination, and then reaching the investigations required either by lab investigations or radiological studies. So by history taking, we are having various signs and symptoms consistent with Cushing syndrome. These symptoms are maybe fatigue, depression, abnormal sleeping pattern, weight gain, menstrual irregularities, hirsutism in females, hypertension, the presence of abnormal glucose tolerance, easy bruising and multiple ecchymotic patches all over the body, the presence of fractures out of a minimal trauma or out of no trauma, what we do assign as pathological fracture. Pathological fractures are considered to be fractures out of no trauma or after a minimal trauma, and they are consistent with cases having decreased bone mineral density and having osteoporosis. However, we are having discriminatory features of Cushing syndrome, that's to say highly pathognomonic signs and symptoms of Cushing. And these highly pathognomonic signs and symptoms of Cushing are considered to be 5 criteria. The first one, the presence of strium. Strium, as you could see here, they are reddish, purplish strium. These are considered to be wide, their width is more than 1 centimeter. They are of variable length, and their presence in particular sites in the body, namely the sides of the abdomen, at the upper chest, the sides of the upper chest, the inner aspects of arms, the inner aspects of thighs, on the shoulders, and on the buttocks. These are the sites for the strium. As you can see here, the sides of the abdomen are the most common site for the strium. They are white, with a width more than 1 centimeter, reddish purplish in color, and the skin overlying they are depressed, Because, as you know, that steroids are catabolic hormones, so they are going to destroy the collagen layer in the skin, leading to thinning of the skin and leading to the presence of depressed striae at the particular size I have just told you. So the striae is the first pathognomonic sign of Cushing, pathognomonic sign of Cushing, and as I told you, the pathognomonic striae of Cushing is said to be reddish purplish white depressed striae. Other pathognomonic signs and symptoms of Cushing consists of plethora, and plethora means the reddish discoloration of the skin, as you could see here in the photo here of this male having Cushing syndrome. As you could see here that he's having reddish discoloration, this lady having the reddish discoloration of the skin of the face, because you know that steroid leading to increased red blood cell count and leading to polycythemia. Moreover, it leads to thinning of the skin with diffraction of the underlying vessels. This is why the patient may experience plethora of the face. The third pathognomonic signs and symptom of Cushing, the presence of easy bruising out of no trauma. So the patient will complain of multiple ecchymotic patches all over the body out of no trauma or after a minimal trauma. So the three mucocutaneous manifestations of pathognomonic of Cushing: facial plethora, reddish purplish white depressed striae, and multiple ecchymotic patches or easy bruising out of no trauma or after a minimal trauma. Other pathognomonic signs and symptoms of Cushing are two musculoskeletal manifestations, including proximal muscle myopathy. And what I mean by proximal muscle myopathy is that the patient is having weakness in his proximal muscle. That's to say, the patient couldn't lift up his hands, couldn't comb his hair well, couldn't stand up from a sitting position because of the proximal muscle weakness of the thighs. So proximal muscle weakness considered to be one among the pathognomonic signs and symptoms of Cushing, and unexplained osteoporosis. So Cushing syndrome is considered to be one of the most common endocrine causes of osteoporosis because it decreases the bone mineral density. And if the patient is having osteoporosis out of no cause, or we are searching for a secondary cause of osteoporosis, so among the causes would be Cushing syndrome. So mind you, these are the 5 pathognomonic signs and symptoms of Cushing: reddish purplish white depressed striae, facial plethora, the presence of easy bruising and multiple ecchymotic patches, the presence of proximal muscle weakness, and unexplained osteoporosis. As I told you, the signs and symptoms of Cushing are various, and there is quite a very long list of signs and symptoms attributed to Cushing syndrome. However, what I just told you are the highly pathognomonic signs and symptoms of Cushing. Going to the physical examination, if I'm going to examine a patient having Cushing syndrome, I'm going to tackle the blood pressure measurement. Those patients having Cushing are said to suffer from hypertension due to various causes. They are going to have obesity, that's having a central type of obesity, truncal obesity. They are having supraclavicular accumulation of fat. They are having, as I told you, facial plethora, striae, thinning of the skin. They're having depressed skin, multiple ecchymotic patches. If the patient is a female, she's coming to suffer from abnormal hair growth in sites which is not supposed to be for a female to have an abnormal hair growth in, and this hair is considered to be a terminal type of hair, or in other term, a male type of hair. This thick, darkly pigmented, long, curly hair present in a female known as hirsutism. The patient as well is going to suffer from a proximal muscle weakness or wasting secondary to Cushing syndrome. So as you could see here, there's this young lady previously, before being affected with Cushing syndrome, and then being affected with Cushing syndrome. As you could see here, that she's suffering from obesity, roundening of her face, what is known as a moon face. But mind you that the moon face is not among the highly pathognomonic signs and symptoms of Cushing. It's just a suggestive sign of Cushing, to have this rounding of the face, what's known as a moon face. As you can see here, that she's having a facial plethora, she's having pigmentation in her face, and I'm going to tell you in a couple of minutes why she's having this pigmentation. This is a child having a Cushing syndrome, what is known as juvenile Cushing. And what I mean by juvenile Cushing, that the patient experienced Cushing in the childhood period. As you can see here, that is having obesity, truncal obesity mainly, is having facial plethora, and the patient is short. This is to assess his stature. This patient is short, because patients, when they are going to have Cushing syndrome childhood period, they are going to turn to be short. And why? Because Cushing is having a deleterious effect on the bone development and the growth in children. Direct catabolic effect on the bones, direct suppression of the growth hormone and IGF-1 axis. This is why patients having juvenile Cushing syndrome, they turn out to be short. And this is why patients to the childhood period commonly prescribe steroids. We are afraid that they would grow to be short, suffering from short stature, because of the deleterious effect of the steroids on the bone and the growth in childhood period. So we now finished how are you going to take a criterion suggestive or pathognomonic of Cushing based on history taking and physical examination, and let's proceed to investigations. How are we going to investigate the case of Cushing? The first thing in the diagnostic workup of Cushing, and please mind you, it's very important that whenever you are going to face a patient with suggestive manifestation of Cushing, the first thing that you are going to do, please take a thorough drug history to exclude exogenous glucocorticoid source, because as I told you, exogenous administration of steroids are considered to be the most common cause of Cushing syndrome. Whatever the source of exogenous administration of steroids, whatever the route, I mean, either oral, parenteral, rectal, topical, inhaled steroids, all of these routes may end up with Cushing syndrome if the patient is going to be exposed for cortisol administration for a long time. Definitely it depends upon the potency of the steroid taken, the dose of the steroids, the route of its administration. Definitely if the patient is taking it as an inhaler, it would be less hazardous as compared to oral or parenteral. So the potency, the dose, the route, the duration of its administration, for how long the patient has been administered steroids. So the longer term of intake, the more liable the patient may develop Cushing syndrome out of the exogenous administration of steroids. Moreover, if the patient is taking concomitant medication that may alter the half-life of the steroid taken, it may lead to Cushing syndrome. So the first thing that you are going to perform whenever you are suspecting a case of Cushing syndrome is to go for a thorough drug history in order to exclude exogenous source of administration of steroids. Who should be tested for Cushing syndrome? As I told you, those having highly pathognomonic signs and symptoms of Cushing. Easy bruising, facial plethora, striae, proximal myopathy, unexplained osteoporosis, and in children who are gaining weight, who are obese and not gaining height. Who are gaining weight and not gaining height. So those who are obese and short, you should screen for Cushing. So the 5 pathognomonic signs and symptoms of Cushing should be screened for Cushing. Those having suggestive features of Cushing. And what are the suggestive features of Cushing? Hypertension, diabetes, polycystic ovary syndrome, hirsutism, A child who is gaining weight and not gaining height should be screened for Cushing. And lastly, who should be screened for Cushing? Those presented by what is known as adrenal incidentaloma. And what is meant by adrenal incidentaloma? Adrenal incidentaloma means an incidental, accidental discovery of an adrenal mass by an imaging technique performed for a cause unrelated to adrenal causes. What does this mean? Say for instance, the patient is suffering from chronic constipation and the internist recommended him to perform an ultrasonography on the abdomen in order to search for a cause. And then when the radiologist performed ultrasound abdomen for the patient, they accidentally discovered the presence of an adrenal mass. So the patient was not suffering from something related to the adrenals, and the radiologist himself wasn't seeking or wasn't searching for an adrenal mass, but he discovered it accidentally. This is known as adrenal incidentaloma, accidental discovery of adrenal mass by imaging performed for a cause not related to adrenal diseases. If the patient is coming to our clinical practice with adrenal incidentaloma, we need to know if this adrenal mass is secreting corticosteroids, yes or no, being the most common functional adrenal abnormality or disorder, so we should screen for Cushing. So to sum up, who should be screened for Cushing? Those with highly pathognomonic signs and symptoms of Cushing, those with suggestive signs and symptoms of Cushing, a child who is obese and suffering from short stature, and those presented with adrenal incidentaloma. How are we going to screen by Cushing? There are four screening tests for Cushing syndrome. The idea of these screening tests, they are based upon two main ideas. Either that the patient with Cushing syndrome is losing the normal cortisol circadian rhythm. And what is the normal cortisol circadian rhythm? The cortisol is high in the morning and low in the evening. Those having Cushing syndrome, they are having loss of the normal circadian rhythm of cortisol with inversion of their normal diurnal rhythm. And the second idea, because cortisol is present high in the circulation, they are going to be secreted in its free form in high amounts both in the urine and in saliva. So these are the basis of the screening tests for Cushing. And what are the screening tests for Cushing? Those are the four screening tests of Cushing, and apart from these four screening tests, all other screening tests are not supposed to be ordered for a suspected case of Cushing. These tests are 24 hours urinary free cortisol secretion in urine, midnight salivary free cortisol estimation, what is known as 1 milligram overnight dexamethasone suppression test, or what is known as overnight dexamethasone suppression test. And the fourth screening one is the low dose dexamethasone suppression test. I'm going to explain for you these tests right now. So the four screening tests you are supposed to carry if you are suspecting a case of Cushing: urinary free cortisol, late night or midnight salivary free cortisol estimation, overnight dexamethasone suppression test, or low dose dexamethasone suppression test. Mind you that the basal cortisol estimation 9 a.m. is not considered among the screening tests of Cushing. If you are having a suspected case of Cushing, don't go just for screening Cushing by estimation of the basal cortisol level at the 9 a.m. If it's going to be high, so the patient is having Cushing. If it is not, or on the other hand, if it's going to be low, so the patient is excluded to have Cushing. This is not the idea in screening of Cushing, because basal hormones in endocrinology have no role in diagnosis of endocrine disorders. We must depend upon more sophisticated tests for diagnosis of the disorders. However, sometimes we do resort to estimation of the basal cortisol level before carrying on with the workup and the investigations for screening of Cushing, just to exclude one abnormality. If the patient is taking an exogenous source of steroids and the patient doesn't know that he's taking steroids. So if the patient is taking an exogenous source of steroids, the patient is going to have a quite high level of steroids in his blood. So the ACTH is going to be suppressed, and the endogenous cortisol production out of the adrenals, they are going to be suppressed. And the cortisol level would be very low, because when we estimate the basal cortisol level, we are estimating the endogenous cortisol level and not the exogenous cortisol the patient is receiving. So if the patient is having the full-blown picture of Cushing I have just told you, and when we estimate the basal cortisol level, it turned back to be low or even zero. So that's to say this is a direct case of iatrogenic Cushing or exogenous administration of Cushing, and the patient doesn't know that he's taking steroids exogenous. However, basal cortisol level has no role at all in the diagnosis or in the screening of Cushing syndrome. Mind you that these tests are not among the screening tests for Cushing. Random serum cortisol or basal cortisol, plasma ACTH level, urinary 17 keto steroids, insulin tolerance test, lobramide test, those are not considered to be screening tests for Cushing. Super added the high dose dexamethasone suppression test. So what I told you, these are only the screening tests for Cushing. For these screening tests, let us discuss about these tests. We are going to start by overnight dexamethasone suppression test. So the overnight dexamethasone suppression test, the idea is to offer the patient an exogenous steroid known as dexamethasone. Dexamethasone is known to suppress the hypothalamic pituitary adrenal axis. It is very potent in this issue. It's known to suppress the hypothalamic pituitary adrenal axis. So if I'm going to offer a patient a dexamethasone exogenously, and then I'm going to measure the cortisol level, it is expected to be low, because I'm going to estimate the endogenous cortisol level. So what I'm going to do, I'm going to offer a patient a 1 milligram dexamethasone at 11 p.m. at night, and then next morning at 9 a.m. I'm going to estimate the cortisol level after being administered the 1 milligram dexamethasone the previous night. If the cortisol level turns back to be low, so this patient is excluded to be case of Cushing, because he follows the normal physiological control of Cushing, which means because I gave him exogenous steroids, ACTH was suppressed, and ACTH was able to suppress the cortisol level to a low level. What is the cutoff level for the suppression of cortisol? 1.8 Ug per deciliter, equivalent to 50 nanomole per liter. So what I'm going to do, offer the patient 1 milligram dexamethasone at night, 11 p.m. Next morning, estimate the basal cortisol. If turned back to be 1.8 or Ug per deciliter or less, this patient is excluded to be Cushing. If it is 1.8 or more, this patient may be a case of Cushing. The 24 hours urinary free cortisol. I'm going to ask the patient to collect his urine for all over the 24 hours, starting from the morning urine sample to be discarded, and then collect his urine all over the 24 hours, including the first voided urine sample the next morning. Then I'm going to estimate the cortisol in the urine. Cortisol is said to be present in its free form, unbound to protein in the urine. This is why I'm going to estimate it in the urine. If the result turns back to be 3 times the upper limit of normal for the lab I'm going to use, this test is said to be positive. Say for instance, the normal range for the cortisol in the urine is said to be, this is an example, from 100 to 300. So the upper limit of normal is 300. If my result is 3 times the upper limit of normal, that's to say 900 or more, so the patient is said to have screening test positive for Cushing. Other tests, the midnight salivary free cortisol, The midnight salivary-free cortisol, it is dependent on estimation of the cortisol at midnight, which is considered to be normally physiologically very low due to the circadian rhythm. And I'm going to estimate it in the saliva because the cortisol is present in the saliva in its free form. I'm going to collect the saliva by a certain maneuver at the midnight, and I'm going to estimate the cortisol in its free form in the saliva. If the result turns back to be double the upper limit of normal, the patient is considered to be positive screening test for Cushing. The last test for screening of Cushing is the low-dose dexamethasone suppression test. The same idea as overnight, but more sophisticated. I'm going to give the patient 0.5 milligram of dexamethasone every 6 hours over the course of 2 days. So say for instance, I'm going to tell the patient, day 1, you are going to take 1 tablet of dexamethasone because the 1 tablet is 0.5 milligram. Take 1 tablet every 6 hours. That's to say at 9 a.m., at the 3 p.m., 9 p.m., and 3 a.m. the next day. Day 2, take it at 9, 3, 9, 3. So he took 0.5 milligram every 6 hours for 48 hours for 2 days, and then the next morning, 6 hours after the last dose, I'm going to estimate the morning basal cortisol level. If it turned back to be suppressed, less than 1.8, this patient is excluded to be a case of Cushing. If it is 1.8 or more, this patient is positive for Cushing syndrome. So these are the 4 screening tests for Cushing, and I'm going to decide based on these screening tests. If the patient is suspected to be a case of Cushing, first consider thorough drug history to exclude exogenous administration of steroids, then perform one of the screening tests: 24-hour urinary free cortisol, midnight salivary free cortisol, or overnight dexamethasone suppression test. If one of these tests turn back to be positive, I need to confirm by another screening test. Low-dose dexamethasone suppression test, despite being a screening test, because it is sophisticated, we do resort to in confirmation of these 3 tests. So if one test turned back to be positive, confirmed by another screening test. You need 2 positive screening tests in order to go for localization of Cushing. Localization of Cushing means where the patient is having exogenous, endogenous hypercortisolism source. So the first step in the diagnosis would be screening. It is a stepwise approach for the diagnosis, starting by screening and then going for localization. If the screening is positive, go for localization. If the screening is negative, congratulations, your patient is excluded to be a case of Cushing. Don't go further. So screening, as I told you, one of the 4 screening tests. Turn back to be positive, confirmed by another screening test. You need 2 positives in order to go for step 2 in the diagnosis of Cushing, which is localization following screening, which is step 1. If the patient screening test turned back to be negative and you are having highly pathognomonic signs of symptoms of Cushing, and that's to say the patient is on clinical basis is highly suspicious to be a case of Cushing, you may use another screening test. If we are having 2 negative screening tests, definitely your patient is negative. So in the screening test, we use 1 screening test, confirmed by another test, 2 screening tests, and then we are going to proceed to localization. In localizing Cushing, we need to know if the patient is having a pituitary cause of Cushing, an adrenal source of Cushing, or an ectopic source of Cushing. And how I'm going to do this? By 2 tests: the ACTH estimation and the high-dose dexamethasone suppression test. What is the meaning of high-dose dexamethasone suppression test? Could you remember when I told you about the low-dose dexamethasone suppression test? In the low-dose dexamethasone suppression test, I gave the patient 0.5 milligram of dexamethasone every 6 hours over the course of 48 hours to physiologically suppress the cortisol level. This dose of cortisol is capable of suppression of cortisol if the patient is having just near physiological elevation of cortisol or having mild elevation of cortisol. However, if the patient is having quite high levels of cortisol in the blood, this low level of steroids given in the low-dose dexamethasone suppression test won't be able to suppress the axis. So if I'm going to sort the causes of Cushing, adrenal, pituitary, and ectopic, and let's see together what about the levels of cortisol expected in these three disorders. In adrenal sources of Cushing, there is direct release of cortisol out of the adrenal, so you'd expect cortisol to be very high. In ectopic sources of production of ACTH, or very rarely CRH, would expect cortisol to be very high because it is coming out due to a malignant elaboration of ACTH. So malignant cells secrete very high levels of ACTH. This is why cortisol would be very high. However, in contrary, in cases of pituitary Cushing, or what is known as Cushing disease, you wouldn't expect cortisol to be that high. So if I'm going to offer a patient a high dose of steroids in the high-dose dexamethasone suppression test, it would be able to suppress the axis if the cortisol is mildly to moderately elevated. In other words, in cases of pituitary Cushing. However, in cases of adrenal or ectopic Cushing, it won't be able to suppress the axis because here we would expect the cortisol to be very high. In high-dose dexamethasone suppression test, what are we going to do? First, we are going to estimate the cortisol level basally before the patient is going to be administered steroids. In contrary to low dose, in low dose, we are going to give the patient dexamethasone for 2 days and then I'm going to estimate cortisol. In high dose, I won't do so. I would estimate the cortisol level at the scratch at the 9 a.m. and then I'm going to offer the patient higher doses of steroids. 2 milligram instead of 0.5 milligram given in the low dose every 6 hours over the course of 48 hours. So 4 tablets instead of 1. So instead of giving the patient 4 milligram in the low dose dexamethasone suppression test as a total in 2 days, here in the high dose dexamethasone suppression test, I'm going to give 2 milligram every 6 hours for 48 hours. So I'm going to give a total of 16 milligram, 4-fold the dose. Quadruple the dose. After giving the last dose, 6 hours after the last dose, I'm going to estimate cortisol. So I'm having now 2 cortisol levels, one pre-high dose and one post-high dose. If the cortisol level post-high dose dexamethasone suppression test is suppressed to a great extent, so the patient is having mild to moderate elevation of cortisol. In other words, he's having a Cushing disease. If it is not suppressed, so the patient is having high levels of cortisol, so the patient is going to have either adrenal or ectopic Cushing. What is the level of suppression? It is 50% out of the basal. Yeah, say for instance that the patient basal test was 42 before high dose, and after high dose it turns back to be 12. So the 50% of the 42 would be 21. If it is more than 50% suppression, so it is suppressed to a great extent, it is said to be pituitary. Here it is pituitary. If it is not, if it is going to be suppressed less than 50% of the pre-high dose, it is considered to be adrenal or ectopic. So in the example of the 42, if it turns back to be 12, so it is more than 50% suppression, so it is suppressed to a great extent, so it is a pituitary. If it's less than 50% suppression, say for instance the reading instead of 42, post-test it turns back to be 38, so it is suppressed not to a great extent, so it is either adrenal or ectopic. I'm going to differentiate between them by estimation of the ACTH. In adrenal, as I told you, because of the feedback inhibition, it is supposed to be very low, while in ectopic Cushing, because it is coming out of neoplastic cells, ACTH is considered to be very high. So these are the 2 tests, lab tests set for localizing Cushing. Step 2 in the diagnosis. So in order to sum up the diagnosis, start by who should be screened. First of all, exclude exogenous sources of steroids. Then who should be screened? Highly pathognomonic signs and symptoms of Cushing, suggestive signs and symptoms of Cushing, child who is obese and short, and those presented with adrenal incidentalome. If you are having these criteria for screening, go for step 1 in the diagnostic approach, which is screening, by using one of the 4 tests: midnight salivary-free cortisol, 24 hours urinary-free cortisol, overnight dexamethasone suppression test, low-dose dexamethasone suppression test. Use one of them. If turns back to be positive, use another confirmatory positive screening test. If I'm having 2 positives, go to step 2, which is localization. Start by the laboratory localization by the high-dose dexamethasone suppression test, high-dose cortisol estimation, give the patient 2 milligram every 6 hours for 2 days and then re-estimate. So I'm having 2 levels, 2 cortisol levels, I mean. If it is more than 50%, it is a pituitary. Suppression, I mean, it is pituitary. If less, it is adrenal or ectopic. Differentiate between them by the ACTH. Based upon the localization, biochemical localization, I'm going to go for radiological localization. If the patient having adrenal Cushing, going to go for adrenal CT scan on the abdomen, adrenal protocol, in order to search for the cause of adrenal Cushing. Unilateral adrenal adenoma or carcinoma, or micro or macronodular bilateral adrenal hyperplasia. For localization of Cushing, for the localization of Cushing disease, we are going to go for the best imaging study for Cushing disease, which is MRI on the sella turcica, the area where the pituitary gland resides. Sometimes we won't be able to find the adenoma because it's quite very small. As I told you, most of the cases are micro by MRI sella turcica, so I'm going to go for another invasive technique for the diagnosis known as inferior petrosal sinus sampling. Inferior petrosal sinus sampling, it is said to be a sophisticated intervention technique for diagnosis of cases of ACTH dependent Cushing if the MRI turns back to be negative, only if the MRI turns back to be negative. The inferior petrosal sinus are said to drain the pituitary gland on both sides, and I won't go into the idea of this test because it's sophisticated. You need to know. I need you to know if the MRI turns back to be negative, I'm having another modality of diagnosis. In ectopic Cushing, how am I going to diagnose? Perform CT, head and neck, chest, abdomen and pelvis, or a PET scan all over the body in order to localize the primary tumor. Maybe it is hidden and we don't know the primary source for the malignancy, which is elaborating a CT in ACTH-like material. So this is the diagnostic approach. Start by drug history. If it turns back to be negative, use one of the screening tests. If I'm having one abnormal test confirmed by another screening test, go for localization by high-dose dexamethasone suppression test. If it is suppressed, so it is most probably a pituitary Cushing, localized either by MRI. If it turns back to be negative, go for inferior petrosal sinus sampling. If it is not suppressed, so it is either ectopic or adrenal, estimate ACTH. If ACTH is low, so it is an adrenal one, go for CT scan. If it is not suppressed, so it is an ectopic Cushing, go for localization of the primary tumor. How am I going to treat Cushing? Treatment of Cushing is mainly surgical. The definitive treatment of Cushing syndrome is said to be surgical, if I'm speaking about endogenous hypercortisolism. So for exogenous, definitely you are going to return back to the physician. Can I stop the exogenous source of steroid? Yes or no? Maybe the patient, the steroids considered to be the mainstay of treatment. I won't be able to withdraw the steroids. So here I don't have any role for the endocrinologist here. So we won't be able to do anything for the patient. If the patient is having endogenous hypercortisolism, the mainstay of treatment is surgery. So if I'm having a pituitary adenoma, I'm going to remove it surgically. If the patient is having an adrenal adenoma, I'm going to remove it surgically. If the patient is having an ectopic Cushing due to malignant lesion, most probably this patient is inoperable. The prognosis is very bad. The life expectancy would be too short. And here what I'm going to do is I'm going to go just for palliative treatment to control the very high levels of cortisol in order to avoid the subsequent complications of Cushing syndrome. So as I told you, the mainstay treatment is surgical. Pre-operative, I need to control, if the patient is complicated with diabetes and hypertension, I need to control the glycemic levels and the blood pressure levels. Those patients having Cushing may be presented with complications of high levels of steroids. They may be having get severe gastritis and may develop peptic ulcer. So I'm going to give a prophylaxis against the peptic ulcer. Those patients are having severe immunosuppression because of the high levels of steroids. You know that steroids are quite immune suppressant agents. So I'm going to cover the patient with broad-spectrum antibiotics before going to surgery. The medical treatment that may be offered for patients with Cushing syndrome, these are the indications to give medical treatment in controlling severe hypercortisolism as a preparation for surgery. If the surgery is unsuccessful and the patient is unwilling to go for redo surgery once more, if the patient is going to be offered pituitary radiotherapy in the treatment of Cushing disease, so bridging before radiotherapy, I'm going to give medical treatment as a preparation for radiotherapy. Or it may be given for patient who is inoperable and it is mainly resorted for cases of ectopic Cushing or ACTH independent Cushing adrenocortical carcinoma. So the indications of medical treatment: preparation for surgery, after a failed surgery, for preparation of radiotherapy as a treatment modality for Cushing disease in cases of severe Cushing syndrome, and in cases who are inoperable, mainly resorted to ectopic Cushing, and cases with adrenal Cushing, mainly and namely adrenocortical carcinoma, because adenomas are commonly resected and the patient may cure after this operation. The drugs that may be given as a medical treatment for Cushing syndrome: either drug that inhibits cortisol production and secretion, steroid synthesis, the ketoconazole, the antifungal drug, the ketoconazole, the mitotane and the metyrabone. These are the commonly used drugs. These drugs are having very deleterious side effects, and sometimes the patient may die out of the side effects of these drugs rather than the disease itself. Drugs that may modulate the ACTH release coming out of the pituitary: either the dopamine agonist, the bromocriptine, or the cabergoline, the somatostatin analogs, the octreotide analogs, the GABA agonist, or the serotonin antagonist. Sometimes we may give something to block the cortisol at the receptor level, mifepristone. So these are the drugs that we do give the patient for Cushing syndrome. What we do commonly give in our clinical practice: ketoconazole, mitotane, and metyrabone. And in some instances, in cases of Cushing disease, we may give the patient either dopamine agonists or somatostatin analogs. By here I ended the lecture of Cushing syndrome. I hope that you knew the definition of Cushing, the most common causes of Cushing in our clinical practice, the classification of Cushing syndrome into exogenous and endogenous, the diagnostic approach starting from history taking and the highly pathognomonic signs and symptoms of Cushing, suggestive signs and symptoms of Cushing, going for diagnostic approach, thorough drug history, who should be screened, stepwise approach for diagnosis of Cushing, starting by step 1, which is screening using one of the 4 tests I told you. If 2 positive, go for step 2, which is localization, starting by biochemical localization, by combined 2 tests, the high-dose dexamethasone suppression test and the ACTH level estimation, and then going for radiological localization by according to the cause based on the biochemical data. If it is Cushing disease, go for MRI, Salaterska. If negative, go for inferior petrosal sinus sampling. If it is ectopic, go for localization of the primary by PET scan. If it is adrenal, go for adrenal CT scan. The definitive treatment would be surgery. Medical treatment is having a minimal role in treatment of Cushing, and it is resorted to some circumstances and having its own indication. I've just told you we have certain drugs in order to control the cortisol level, even either tackling the cortisol synthesis and production itself or modulating the ACTH release in cases of Cushing disease. Mind you that the most common cause of Cushing syndrome in general is iatrogenic, exogenous administration of steroids. However, the most common cause of endogenous hypercortisolism in adults is considered to be Cushing disease, or in other words, pituitary Cushing in adults. However, in children, the most common cause is adrenal Cushing. So in adults, the most common cause of endogenous hypercortisolism is considered to be pituitary Cushing or Cushing disease. And thank you.